the Institute of Diabetes, Endocrinology and Adiposity. Thyroid truths and nodule insights. So if we think it is a thyroid nodule, of course we would be interested in whether it is growing. So it's the basics of any swelling anywhere in the body. How long the patient has had it, how fast it's grown, is it painful? And coming to certain thyroid specific points, are there any obstructive features? Is there voice change? Is there difficulty swallowing, difficulty breathing? So things like that to give us a clue as to the possible nature of the problem. Family history would again be important, especially in younger patients. This patient was in his early 30s, so we would ask for a family history of the probably cancer syndrome or for a family history of thyroid nodules or thyroid tumors. Past history would be relevant with regard to exposure to radiation or a history of head and neck radiation for some other cancer management in the past. Examination-wise, the size of the nodule will also give us an indicator as to the line of treatment that would be necessary later. So generally, we see nodules more than 3 or 4 centimeters will need closer evaluation. We will need to observe them more for signs of obstructive symptoms. So the nodule here is around 6 centimeters in the longest dimension. We would also look for the texture of the nodule for mobility. So here the nodule is mobile, which is good in the sense that malignant nodules have more of a chance to be fixed. So how do we approach investigation in these cases? So once your physical examination is done, investigations would be generally biochemistry and ultrasound. So two things which are definitely needed for all patients are, one is the TSH. So in case the TSH is low, the approach would be slightly different. In case the TSH is normal or high, the approach would be different.
In the case of thyroid nodule with clinically patient not having any obvious hyperthyroid symptoms, but however the biochemistry revealing hyperthyroid status with TSH. Thyroid scintigraphy, we usually call as the perfected scan.
దానిలో ఎట్లా ట్రాన్స్లేట్ అయితే అట్లనే వస్తాను దానిలో ఎట్లా ట్రాన్స్లేట్ అయితే అట్లనే వస్తాను
or a warm or a cold nodule. But in this case, we usually expect a hot nodule. However, the size wouldn't be a fitting factor for this. If it was a suppressed TSH, definitely thyroid might help in characterizing the nature of the nodule.
Yeah, ultrasound for the thyroid surgeon or an endocrine surgeon is like a stethoscope for the cardiologist. So we can't see any patient without doing the ultrasound. It's very important. So when we look at the ultrasound here, what we can see is the nodule looks predominantly a solid nodule. We can see a few cystic spaces, and the nodule also seems to have peripheral vascularity. And probably it is hyper to isoechoic compared. There's only a sliver of normal thyroid tissue though. So what I understand, it means it looks like a neoplastic lesion when it's a solid lesion. And if it had more than 50% cystic component, then I would be happy. Okay, most likely benign. But sometimes this minimally invasive follicular carcinomas can have this solid appearance. So when I look at it, I am a bit concerned, and I would ask for the next investigation. That's a fine-needle aspiration cytology. Thyroid scoring, each ultrasound feature is given a score. Like if you look at the consistency, and the consistency if it's a solid lesion, and whether it is solid or cystic lesion, or it is purely a cystic lesion, that's one. And then you look at the echogensity. If it is isoechoic, you give only 0. If it is say hypoechoic, then you give a point of 1. So every suspicious feature is given a score. Like if the patient is having any echogenic foci, particularly if a patient is having microcalcifications, then we give a score of 2. If it has macrocalcification, it also is given a score of 1. So every suspicious feature in the ultrasound is given a score, and when we add up all these scores, like there are several thyroid classifications. The first one which was described was the Korean by the Kwak and et al. So he was the first person to describe this, and they used the 5 common things, and if it is thyroid 4 and above, then they recommended a fine needle aspiration cytology. And now we have others, like the commonly used one now is the ATA, American Thyroid scoring for thyroid. It helps us in deciding which patient we can keep them on follow-up. If the thyroid score is low, thyroid score is 2 probably, and we can keep them on follow-up without FNAC. If the thyroid score is high, 4A, 4B, 4C, then you recommend a fine needle aspiration cytology to take it forward.
Good you brought that up. I did want to briefly talk about the Bethesda system, which is the cytology equivalent of the thyroid system. And again, from 1 to 6. 1 is usually inadequate, and we used to have an earlier category of 1C, which was if we saw only cyst, macrophages and colloids. 2 is benign thyroid lesions, like the earlier one, where there is no architectural or cytologic atypia, cellularity is moderate, plus there is a benign colloid. 3 is, of course, the contentious area. It's a grey area essentially. In the current Bethesda categorization, which is Bethesda 2023, so we recently had an update. There is a lot more information on how to deal with category 3 of Bethesda. Earlier, informally we used to categorize it as AUS uncertain significance and AUS follicular. Right, so based on cytology or architecture, but now they have kind of formalized this, and you have 2 categories of AUS. Category 1 is where there is cytologic atypia. Category 2 is where there is architectural atypia. And we say uncertain significance because these the features do not add up to a diagnosis of say category 4, which is follicular neoplasm, or of papillary carcinoma, which would be a category 5 or category 6. So these cases have atypia, but the atypia is insufficient for an actual categorization of malignancy. So these smears are categorized as uncertain malignant potential. Again, based on either cytology or architectural atypia. For cytology, we are looking at maybe diffuse atypia, mild nuclear enlargement, irregular nuclei, maybe subtle features of papillary carcinoma, occasional grooves, occasional nuclear overlap, or irregular nuclei. So those are the cytologic features. In terms of architecture, we are looking for a microfollicular pattern, right? And again, like I earlier mentioned, always there isn't much colloid in the smear. When we see a lot of colloid, we're usually reassured. It's usually not atypical or malignant. It's more likely to be an adenomatous or hyperplastic nodule. So now current AUS category 3, that is of Bethesda, includes AUS C, which is with cytologic atypia, and AUS A, which is with architectural atypia. And these are categorized according to what we say is risk of malignancy. So there is evidence to show what is the risk of malignancy with each category, and further, at least in the West, they've used extensive molecular profiling. So the risk of malignancy is higher in the cases with more cytologic atypia, where you see crowding, or you see enlarged nuclei, you see some subtle features of papillary carcinoma. And many of these cases are actually NIFTP, which currently, it's just again a grey lesion. Do not really consider it malignant. So a significant number of cases with Bethesda category 3, which which are called out because of cytologic atypia, are actually NIFTP. The other category are the ones with microfollicular pattern, similar to this one. It was called a category 3, but it turned out to be nodular hyperplasia. So nodular hyperplasia should usually show the macrofollicles, but if it has a subtle microfollicular pattern, then it will be a category 3. If the architectural atypia is more, there are sheets of microfollicles, and with architectural atypia and lack of colloid, then that will be category 4. Ultrasound again was indeterminate. The FNAC had certain features which were concerning. The patient is in his 60s, about 59 or 60 is his age, 59. So if it was a younger patient, we would advise closer follow-up. The patient preference would also be in favor of definitive management as opposed to long-term follow-up. So in patients more than 60, the chances of malignancy in these sort of patients is on the lower side.
So one approach would be to keep the patient on follow-up, repeat an ultrasound, and ideally another FNAC.
ఇది
Okay, the second FNAC
లైవ్
might give us
నడుస్తుంది వైడ్
direction. It might
క్లోజ్
either
చేస్తాం
be
ఓకే
benign
ఉంచుకోగానే
or in case it
ఫ్రేమ్
comes as
మార్చేటప్పుడు ఏంటంటే వైడ్
suspicious
తీసుకొని
for
క్లోజ్ చేసుకో
malignancy
డైరెక్ట్గా
or
తీసుకో
any of the other things,
అర్థమైంది
we could go for surgery. So one
నేను లైవ్
approach
స్ట్రీమింగ్
would be
పోతాను
to
డైరెక్ట్గా
look at
వీళ్ళు
the
చూపిస్తున్నాను
patient's wishes, and if he is alright with follow-up, we could advise an ultrasound followed by an FNAC at a reasonable interval. However, if it was a younger patient, or in this particular patient the concerns are the nodule is on the larger side, he has obsessive symptoms, one approach would be to repeat another FNAC at the same point. Molecular mechanisms of diagnosis are not yet widely available in our setup, so if available, that would possibly be an approach to help us decide whether to go for surgery. So either way, considering the size of the lesion here, indeterminate features of ultrasound and FNAC and obstructive symptoms, I would possibly refer him for surgery at this point.
One thing we have to see is if it is hypoechoic. So this looks hypoechoic, one. And then you look at the margins of this. These margins are sort of irregular margins. And then we look at the point of contact of the solid component with the lesion. So if it has an acute, like in this case, you can see the solid component is like this. We upgrade this lesion and it looks like a suspicious lesion of ultrasound. I think the contralateral lobe also has a lesion, and which again is hypoechoic, and it has irregular margins, and there is a foci of calcification, probably a macrocalcification. So hypoechoic nodules are suspicious of malignancy, around 40 to 50%. So yeah, this also need to be addressed in this patient.
Again, going back to Bethesda, suspicious is a category 5. An actual PTC is a category 6. Usually with fabric carcinoma, we give it a category 5 when there is insufficient material. Supposing, I mean, like we are seeing in the picture, we just, the top one, I mean, we just had a single fragment, say, with minimal nuclear features. If cellularity is low, then obviously we cannot go ahead and call it clear-cut malignancy. So it is in those cases where it does show features of fabric carcinoma, but cellularity is low. These are the patients that are categorized as Bethesda 5 and suspicious of PTC. Whereas when we say category 6 and we call it out as a fabric carcinoma, it has all the features. Again, like I said, we're looking for cellularity, colloid architecture, and cytology. In fabric carcinoma, we're looking for the bottom picture shows those large papilloid fragments. And you can see that the fragment is rounded, and you can imagine that that's a papilla. I mean, with the central fibrovascular core covered by PTC cells. So we're looking for monolayering, we're looking for papilloid fragments. And in terms of cytology, we're looking for all the classic features of fabric carcinoma, which again is nuclear irregularity, overlap, grooving, cytoplasmic inclusions, and then some soft features, bubblegum colloid, some of what is like Dr. Siddharth just mentioned. So all these would actually go towards a category 6. In category 3, right, if we see just samoma bodies, we do not see any nuclear features, then we tend to call it a category, whether it's a category 3.
So that we can explain to them that this is the actual rationale of giving the therapy. So in this case, classical PTC, though it's a multicentric lesion, less than 4 centimeter, except for the presence of extrathyroidal extension, there are no high risk features. So it would still fall under low risk. This extrathyroidal extension feature alone raises it to intermediate risk if it is limited to the strap muscles. And so in a intermediate risk category, we would definitely want to give some adjuvant therapy to address the whatever remnant tissue that might have been left over post surgery. So we maintain the patient on hypothyroid state for the next few weeks and raise the TSH. Would want the TSH to be at least more than 30. And like regarding the post-surgery pre-therapy diagnostic scan, it's a case-to-case basis. It's tailored based on the need. In this case, if we're going for a 30 millicurie adjuvant ablation therapy, that's pretty we plan it based on the again the decision is based on sometime in the next case we can discuss. We had a case where the thyroglobulin levels would also matter. The pre-treatment thyroglobulin levels would also give an idea regarding how much of disease burden is still left over. So based on the risk factors, the stratification and the thyroglobulin levels put together, we stratify the dosage to the patient.
Yeah, this patient had two FNACs and both were reported as benign at two different centers, and this patient had come to us and she wanted microwave ablation. So she was not keen of removing a part of the thyroid. So, but yeah, so again, as I said, it is not just an FNAC which helps us in making the decision. So you have to look at the ultrasound also. So the ultrasound is a solid lesion, doesn't have colloid cystic spaces. So that says that, okay, this is a neoplastic lesion. Either it could be a follicular adenoma or at least a minimally invasive kind of thing. And then, yeah, as I said, it's not, and how it feels to the finger, to the thumb. If it is a soft, freely mobile, then more chances that it might be. Yeah, it is subjective, I understand. But when you put your finger, you know, okay, it's a firm nodule, it has a bit of a restriction. And when we take all these things, the clinical examination, then the ultrasound features, and then the FNAC, and we make, and what exactly the patient wants. So these are the things. So when we did it is a classic, what do you call it, minimally invasive follicular carcinoma. And the next question comes whether she really needs completion thyroidectomy or not. Yeah. So, and she, as I said, doesn't want to lose thyroid. So how are you going to manage her? So yeah, ideally she will need minimally invasive follicular carcinoma more than 4 centimeters will need completion thyroidectomy as per the guidelines, because there's a 5 to 15% risk of distant metastasis coming up over the future. But again, can you individualize in this patient? So yeah, if the patient has more than 4 vessels which are involved, more than 4 vessels, vascular invasions, these are the patients, when you follow them up, might come up with a metastasis later. This patient had only 1 foci of capsular bulge. So taking this into consideration, yeah, she wants to be on follow-up. Yeah, we can keep them on follow-up. We monitor serum thyroglobulin and then keep her on follow-up. Yeah, with an intact thyroid gland, is it going to make much of, how can you assess this? That's a controversial topic, whether you can, with an intact gland, can you assess the thyroglobulin? So yeah, usually each gram of thyroid produces 1 unit of thyroglobulin. So we monitor, and post-op after 3 months, if the thyroglobulin is say below 50, I am happy. If thyroglobulin is say 200, then I am doubtful, and I would recommend completion thyroidectomy.
Study where post surgery, in cases of hemithyroidectomy, where thyroglobulin levels are reliable in following up those patients. They say that there might be simultaneous Hashimoto's that happening, and yes, definitely, as said, if there is a marked increase, that might help in being alert and addressing that. But for certain changes, we will not be taking it early. And regarding radioactive iodine therapy, yeah, these are the patients. So when we are contemplating a follow-up, and when the patient doesn't want to undergo surgery again, there is a updating the residual of the thyroid with logos. And ideally, we would want a completion thyroidectomy to be that when the patient comes to us, so that we don't need to give multiple I'd like to give the perspective to the audience. So the trend of radioactive iodine was somewhere from varies. We give the dosage somewhere from 30 to 200 based on the various factors like the risk categorization and the level of thyroglobulin that we see, and also the findings that we see on the diagnostic scan. And after 2015 onwards, the last ATA guidelines were released in 2015, and the next edition is expected in this year. So in the 2015 there was a trend of de-escalation where the low-risk patients can be followed up. Is a statement given on ATA, and after that we significantly saw the surgeons not sending the patient even to nuclear medicine. But yeah, however, this needs some validation with the data. And previously it was about more a debate on whether we should give 30 versus 100 millicurie in a case of low risk case. And there were two trials conducted in the context, the ILO trial and the Sustainable 1 trial. These two trials have proven that whether I give a 30 millicurie for updating the length or 100, the difference was not much, like it was equal, like the results were the same. So there is a trend that came from 100 to 30. So in all those low risk cases, unless we are doubtful about the histopathology itself, or if the thyroglobulin is very high, or if there is a aggressive variant or something, we usually tend to go to 30 millicurie. Now again, there have been further trials, the Experiment 2 and as well as the ION trial, and ION trial got published last week with a follow-up of almost 6.8 years. And Experiment 2 published the 3-year and 5-year results, where non-inferiority of surveillance alone was documented as compared with the 30 millicurie radioiodine ablation. So, like, yeah, we as nuclear physicians, we are always would want to give that 30 off and want the TG to be more reliable marker, so that once we update all the tissue that is there, any increase in thyroglobulin would be a very sensitive parameter for further evaluation. We can pick it up early. So, and even the recent ATA, it have to come into publication, but the main author, the chairman, also says that they studied similarly a large set of patients where post-op without radioactive iodine, whether they can have a specific cutoff. But I think they are coming up with a cutoff of 2.5 to 5, that range, as the cutoff value in those who are not treated with radioactive iodine. So once these guidelines are published, I think there will be more debate, and this stratification of low, intermediate, high is going to be more complex with the low category, low to intermediate, intermediate to high, and high. They are introducing one more category in the newer system that is going to come. So I think we may be having more panel discussions and more debates going forward.
That's wonderful, sir. I'm sure there is a lot in
biology of the disease has not changed. We keep changing the terminology. So thanks to PTC, it's still, it's a good tumor, and we can
that is true, sir.
reassure the patient at the end of the day. Thank you.
We have actually had, all of us who have had patients, especially endocrinologists, come up to us with calcitonin values. They don't actually wait to ask us NJ values. So I think I would not use GLP-1 analogs if I thought the patient had a family history of Men's syndrome, history of medullary thyroid cancer in the family. However, if they actually come with a calcitonin value and it is sort of less than 30, we can reassure them probably and send them up. In the interest of reassuring the patient, we could also probably do an ultrasound and have a baseline check on the features of the nodule. So in most cases, calcitonin would not be indicated in someone we are considering for GLP-1 therapy.